voice from the world of autism,
early educational intervention,
and a West River Hospitalist program.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard, blow, 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 keep pushing.
And try to fish your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. This is going to be a fun show tonight because it's one of our regularly scheduled Ask Anything broadcasts. Later in the show, we'll bring you an interview with an autism spokeswoman, Temple Grandin, one of Time Magazine's 100 Most Influential People of 2010. We'll also bring you a report that explains what kind of doctor a nocturnist is, and as usual, our doctors on the set will answer the questions you call in about health issues that are important to you. Joining me tonight in the studio are Dr. Thomas Braithwaite, Dr. Sarah Smith, and our on-call medical editor, Dr. Rick Holm. You can call in with your questions about any health concern tonight. Our phone number is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. Helping answer the phones tonight are volunteers from the South Dakota State University Pre-Professional Science Club and the SDSU Nursing Student Association. Dr. Holm, before you introduce our guests, I want to ask you, when you saw your patients this week, did any of them ask you a question that you thought, this person is on target, they're really thinking about managing their health care?
Oh, they're all trying to figure it out. Sometimes they are right on the target, and sometimes they're way off in left field. But everyone, you need to listen to everyone, and you need to value them. It's that some have better questions than others. I mean, there's no question about that. There has been this has been a very challenging week, and sometimes people are happy, and many times people who are sick are not happy. And if you're not happy, some of the brunt comes this way. So it's a challenging job. I thought about this week and went, ooh, this is hard. It's not an easy thing. But a lot of good, challenging questions this week.
Okay, and this is a great time to ask your questions and not worry about
any repercussions.
Yeah, you can ask anything.
Well, and I want you to know these are two of my favorite people tonight. And I'm pleased to introduce to you our guest for this evening. Dr. Tom Braithwaite is the hospitalist for Sanford Medical Clinic in Sioux Falls, and Dr. Sarah Smith is from Avera Brookings Medical Clinic, a family physician. So we've got a hospital internist and a family physician with us tonight, and actually they're kind of mean. They're mean people. I struggle with dealing with these people.
Yeah.
So, Dr. Braithwaite, now you've been on the show once before. I think so have you, Sarah.
I think so.
So who are you, and what the heck do you do? I mean, what is a hospital internist?
Well, Rick, as you know, my training was similar to yours. I trained in internal medicine at the University of Iowa, and then I think if there had been an opportunity to do hospital medicine in 1985, when I came out of training, I would have done it. But I did what I thought was the next best thing, which was general medicine at that point. But then in 2003, I moved over to the hospital full-time to help Sanford begin its hospice program at that point.
So you and another guy were
Bob Hauser and I were the first two there, yeah.
There you go. And Sarah, What is a family physician anyway? How is it different than an internist?
Well, my training was in family practice, and we take care of patients of all ages. So people ask, do you like seeing kids? Do you like seeing older people? Or, what do you do? Some family physicians deliver babies. A lot of family physicians are trained to do that, but we take care of people through every stage of life. So the fun part of that is that I get to have families. I have, I get to see babies and parents, and even their parents, and as they're getting older. Or
so a family physician is a internal medicine doctor, pediatric doctor, and a OBGYN doctor.
Yes.
All wrapped into one. We trained for 3 years. We're not, most family practitioners don't do surgeries like C-sections. Some do. But, I think I think it's fair to say that there's maybe a little bit more breadth and not as much depth in certain areas. And that's the hard part when you see people of all different ages. You can't know everything about everything at all stages of life. So I think that's part of being a family practitioner, is that I enjoy variety. I like seeing people of different ages, but you also have to really recognize when you don't know what's going on, or if you need the help of an internist, or if you want to, ask something of a specialist, or so. When do you need to call for help? That's the question. But that a general internist, an outpatient and hospital internist, like I am, and a hospitalist internist, we all need to have a time to call for help. But I call for his help sometimes. You've called for mine.
There you go. That's right.
Well, thank you both. And of course, this is we're going to take any question. I challenge you. Stump us. You can't get a question that you're going to that we won't know something about. We'll be right back after this break.
Symptoms of autism usually start before age 3 and can cause delays in many skills that develop from infancy to adulthood.
For our first story, we're going to take you West River to learn about the Hospitalist program at Rapid City Regional Hospital. And Dr. Braithwaite briefly mentioned hospitalists. You're going to learn a little more coming up. Hospitalists are physicians who work only at a hospital. You won't see one when you make an appointment to come in at a clinic. So here's more about the Rapid City Regional Health Hospitalist program and a chance to learn about another specialized type of doctor, the nocturnist. At Rapid City Regional Hospital, a group of physicians work together as a team. They are the hospitalists and nocturnists. Dr. Chad Hanna explains.
Nocturnist is basically a position that has spun off of the traditional hospitalist model, whereby the hospitalists in our program basically are taking care of hospitalized patients, and the 6 of us have spun off and become nocturnists, where we work from 5 p.m. until 7 a.m. the next morning, taking care of those same patients during the nighttime hours.
Dr. Tony Blair is the co-medical director of the Hospitalist program at Rapid City Regional Hospital.
So essentially we're all, at least in our program, internal medicine trained, board-certified physicians.
Dr. Blair says the benefits of the Hospitalist program extend beyond just improving care within the hospital walls.
What it does is it really allows the primary care physician to remain in their office seeing their clinic patients. And so they have fewer cancellations where they have to respond to emergencies in the hospital. They don't have to leave their office to do admissions into the hospital. So they're really able to focus and take care of their outpatient clinic patients without disruption.
The hospitalists track and meet about patient cases and are part of an effort to reimagine how patients are cared for. Dr. John Luby elaborates.
The new areas, though, that are kind of exciting is not only are we able to spend more time in the hospital seeing patients and stuff, we're also part of trying to redevelop the hospital, trying to gear the hospital towards patient-based and all the needs around the patient, instead of, it used to be, based on the physician's needs, based on the nurse's needs, based on the facility's needs, kind of thing.
I was talking to one of my family practice friends the other day, and he told me that he didn't really realize how tired he had been for the last 20 years until we took over the care of his hospitalized patients. And it, you know, he said that it has just allowed him to concentrate on his clinic, and that when he starts his clinic in the morning, he's much more refreshed, and he feels like he's at the top of his game.
Doctors, let's start out real quick by explaining the advantages of using a hospitalist for both patients and physicians or hospitals. And then we've already got questions to go to.
Okay, the advantage of doing hospitals. Before you say that, though, hospitalists are commonly internists or family physicians. So I like to think of them as hospital internists, hospital family physicians, hospital pediatricians.
About, although hospital medicine, Rick, you know, emanated in the adult world, there's been a large amount of growth, particularly within the last 5 to 8 years in the world of pediatric hospitalists. And again, most pediatric hospitalists get training in general pediatrics, but then practice their craft just within the hospital setting. Within adult medicine, which is the world I'm in, about 85 to 90% of adult hospitalists got training as in internal medicine, the others by family physicians. We also incorporate mid-levels too. Much as you see mid-levels working within outpatient settings, mid-levels have become an important part of the inpatient team now too.
Anything to add, Sarah, on that?
No, I think, you know, it's coming from you know, my residency in Lincoln, Nebraska, where we did train with some hospitalists and did some rotations with them, and hospitalists were available there, so that really made a difference for the family practitioners that were practicing in Lincoln. You know, coming here to Brookings, where we don't have hospitalists, you know, we have people who like to take care of hospital patients, but, you know, the size of the community, you know, doesn't lend itself to that, or whatever the reason is, but you know, I feel like I've kind of seen a little bit of both, you know, both sides for sure.
I remember you and I had this conversation when you were thinking about this going into being the hospitalist, and I thought it's a great thing, and I was a little bit jealous because really most of my training was in the acute, in the hospital sickness. The only problem is that really a lot of the delicate, hardest stuff to do is sometimes that balancing act of getting them to function at home. You need to have somebody to send them to take care of them as an outpatient. And a lot of the internists who are used to taking care of very complicated outpatient people are now disappearing into the hospitalist programs. Who is going to take care of our future hard, difficult, challenging, elderly people when they come out of the hospital and need to be cared for as an outpatient, Tom?
Well, I think there's two aspects to that question. One is can you work well separating outpatient and inpatient care? And I think the answer to that is yes, although there's roadblocks, and there are communication roadblocks. You have to work out collaboration between the team that's taking care of an individual on the inpatient side, as well as that team, not just the primary care doc, but the team, the clinic, the sort of the receivers on the outpatient side too. It can work, but you have to recognize the communication levels that are necessary. Now, the second part of that question is who's going to be it, is the grander question of primary care in general and the shortage that I think we are all aware of, not just in this state, but nationwide, and the shortage that's going to, we fear, become exacerbated in the years to come, the shortage of primary care physicians, whether it be inpatient, outpatient, or both.
Yeah, it's a big question. I mean, it's a huge problem. Yeah. And politically, our leaders, both in medicine and in Washington, need to be directing us better in this way, I think.
Okay, the questions are already coming in, and this was one that was emailed in a little while back. A 77-year-old male with a long history of nasal congestion and drainage, and he just kind of wants some comments. I find the saline solution nasal sprays helpful, especially a self-spritzing can. It even helps when I have a sneezing session with 8 to 10 sneezes in a row. And his question is just any comments. So if you
steroid nasal spray, yeah. I really like that. What's your comments?
Yeah. This guy says he's using saline solution nasal sprays.
Saline's great, but I really think if it's an allergic process that's continuing, the steroid really helps.
Nasal steroids are helpful. Sometimes antihistamines, if this is allergy-based, even oral antihistamines over the counters like Claritin, Loratadine, One thing we want to caution people about is using certain sprays like Afrin, ephedrine sprays. These can be used for very short periods of time, and they really do reduce congestion, but they can also cause almost an addiction of the nasal passages to that effect, and they're never meant for use for over 24 to 48 hours. So be very careful with those.
Huge.
Okay.
Sarah?
I would agree.
Okay.
Next question, a question from a 69-year-old female, and she was told to take 1,500 units of calcium a day. On a previous show, Dr. Holm, you mentioned that you're not necessarily recommending people take calcium. This caller wants to know what is calcium doing or not doing for me? Caller also takes 1,000 units of vitamin D daily. Physicians on the show had mentioned previously that you could take up to 2,000 to 4,000 units. This caller says, I took 3,000 units one day and I was awake most of the night. What time of the day should I take vitamin D with meals or not? So let's calcium, vitamin D.
I think that the vitamin D, you have to realize that it's all kind of there. It's all important. I think if you can get most of your calcium through your diet, and maybe add a vitamin D supplement, I think that's a great way to approach it. If for some reason you can't drink milk, or there's another reason that you're not getting calcium. That's how I approach it. I also think too it's important for people to know, if they're at risk, have risk factors for low bone density, or if they have osteoporosis or osteopenia, low bone density, then there might be different recommendations for that. So that's kind of how I approach that.
Yeah.
Risk factors, if you're a skinny white woman, is that pretty much?
Skinny white woman, thin, light blue eyes and blonde hair, and smoke.
Family history.
Family history.
Sedentary life.
Yeah. The Institute of Medicine, is very conservative. It says we should at least be taking 600, and if you're elderly, 800 a day, and you're safe at 4,000 or less. So I go 2,000, and there's some data that suggests, not proof, that calcium is dangerous, can cause atherosclerosis. I like what Sarah said about getting it in your diet.
And I would also tell the caller, whoever sent in the question, that there really isn't any link between modest doses of vitamin D and insomnia. I don't think there'd be a connection there, and there really isn't any ideal time of day to take vitamin D.
But people have weird reactions to things. Every individual has to.
With food, without food, take it?
Calcium is best with food. Vitamin D doesn't really matter.
Okay. All right, this next question, we had a really nice letter. It's a couple of pages here. I'll try to condense it.
Read the whole
I'll try to condense it. It's from Vermilion. Let's see. Lady had a lump or a knot in the axilla ligament of my front right armpit. She's had physicians look at it over the years. They did not know what it was. It doesn't hurt, and they suggested surgery, but it didn't seem to be bothering her, so she avoided elective surgery. After 6 to 7 years of examining it annually, they finally did a biopsy. The conclusion was not sure. That's the physician then said he wasn't sure what it was, but he still thought she should have it removed. It's slightly larger than it was 20 or 25 years ago, but the lady who wrote this is 84 years old, so she thinks she's probably going to outlive whatever it is. I don't feel right about having elective surgery when it's causing me no pain or bother. To what kind of doctor should I go to get this diagnosed?
Tom?
Well, it's a skin problem. I guess if she wanted to seek a dermatologist, she could. But from the way that this is described, basically a asymptomatic, painless lump of the skin in the armpit, that's the axillary region, that's not changing or changing minimally over decades, the likelihood that this is anything serious is nil. And it could be a lipoma or an epidermoid cyst, an oil gland cyst, and the likelihood that this would be anything serious when it's unchanging over such a period of time, I think it would not be unreasonable to just continue to monitor.
Yeah.
Okay.
Watch it.
I have a question about the biopsy not being really giving clear-cut results.
Join the club. I mean,
so that's not an uncommon thing.
You go for that biopsy and you go, okay, it's going to have the answer. It's going to tell me, yes, I should do this, or no, and it comes back, well, can't, you know. And that's the answer. The guy looks at it and can't make the decision.
Or there's not enough tissue, you know.
Or they missed
try
it.
to aspirate it or, you know, take a small piece of it. Sometimes they can't. There's just not enough to look at.
Most things of this size, the way to biopsy is excisionally to biopsy.
Yeah. Take the whole thing out.
You remove it. But again, hating to give advice over the TV or the phone, but from how it's described, I'd be pretty certain there's a benign process.
84 years of age, done well, leave it alone.
Okay. A question from Sioux Falls, age 64 gentleman, recently diagnosed with RLS. Is there anything he can do to help? He's taking 0.5 milligram Miropex, 0.5 milligram clozapam, but they make him sleepy. Now, I don't know what RLS is.
Restless leg syndrome.
Okay, great. What? So the medications make him sleepy. Is there any?
Well, I'd say medications that are used for this kind of fall into a couple of different buckets. You can use medications that, since this restless leg syndrome is most common at night, oftentimes sedating medications from a class we call benzodiazepines. The person who sent in the question is on clonazepam. Medications like that can be helpful, and they are intended to be sedating. That's why they're usually administered at bedtime. But there are other medications that, although this isn't a condition like Parkinson's disease, which is a movement disorder, restless leg syndrome can respond to medications that are used in other movement disorders. Miropex would fall into that class, so with Sinemet, which is a medicine we use for Parkinson's disease. Those tend to not be sedating and can be used dosed during the day, because sometimes people will notice if they're inactive for a period of time earlier in the day that they need something. Miropex, Sinemet, medicines like this can be utilized then, but usually it's the greatest problem at night, so I wouldn't see the sedation, unless it's excessive, as being a big issue, but might want to work with his physician on a lower dose or adjusting that.
I like Miropex as a treatment, but it has side effects with hallucinations. I don't like Sinemet because you got to use the next higher dose, but then it gets worse, and you get a higher dose, and then you get a higher dose, and then when you stop it, you get withdrawal, super restless leg. So I try to do the Miropex or the pramipexole or the other atypical Parkinson's disease drugs. If those don't work or you're getting into that trouble, a clonazepam-like drug, but I prefer a short actor than the long-acting clonazepam, Ativan kind of a thing or something like that. Yeah. But you got to be careful. Those are addictive. They make memories people get confused.
And I think, too, that, I went to a conference on neurologic disorders, and the gentleman doing the talk on the restless leg said, that you should look and make sure that they're not anemic, because sometimes anemia can so make sure that they're not anemic and that they're getting enough iron in the diet. And sometimes those, it's very familial, too, so I try to ask people about family history of that, too. So.
Okay. Mucinex, a gentleman from Sioux Falls. Can Mucinex cause a bad taste in the mouth? Now, what is that an over-the-counter?
It's a mucolytic. There's some people who say it doesn't work very well. I've always poo-pooed it until a patient came up to me and just convinced, and I've tried it a few times for patients, and they like it. I don't know. What's you guys' experience?
Not very positive, I'd have to say, although sometimes, particularly people with chronic lung disease who have real problems clearing their large airways. I know lung specialists who are very fond of using it and feel that it can be of some incremental benefit. So now in terms of having I think the question was a bad taste. Yeah, I think that often is a complaint you hear from people who take it.
Tell them what you use, Mucomist. Is that a related mucus breakdown? What do you use Mucomist the most for?
In the hospital, we use it for Tylenol poisoning. So
yes.
I'm a hospitalist, so that's the world I work in. But
so, it tastes awful. So it might be the drug that's giving you a taste.
If I've had too much Tylenol, and
we might give you Mucomist, huge doses.
It's an antidote for Tylenol poisoning.
Don't even go there.
Yeah.
Okay.
Not what the caller was.
Yeah.
It's another story.
For sure. Yeah.
Okay. Well, let's. We'll put you on the spot. Question from Peaver, and gentlemen chime in. Lady, I have rheumatoid arthritis. what causes the cysts that I get. Does not identify where the cysts are.
Rheumatoid cysts.
Probably at the joints.
Yeah.
Okay.
I mean, or nodules might be on.
Or likely the nodules along the.
Yeah.
And I don't think anybody knows.
Well, rheumatoid arthritis is not just a joint-related disease, it's a systemic disease. And within the muscles and tendons of, particularly on the extensor surfaces of the arms and the legs, you can get inflammatory nodules within the soft tissues. I suspect that's what the caller's getting at
and it's
here.
an immune system thing. Although you can get cysts in bones too, can't you? I mean, it deteriorates the bones such that there's cystic deterioration. Maybe I'm thinking of another one.
Okay. Maybe that one stumped you. No? No, we know.
We had a good answer with
we
the
know
nodules.
that we don't know what causes the cyst, right?
Okay, we admitted that.
Oh, no, we know it. That's an answer. I'm sorry. Question from Flandreau, a lady, age 57, recently had a cervical epidural for neck pain. I had a shot and the pain is gone, but I feel sick all the time. I'm wondering, is this from the shot? So, what's an epidural? And then answer her question.
Epidural is a space. It's not into the spinal fluid. It's the space just outside the spinal fluid, but inside another lining. So there's just this space, and it works like injecting into the spinal fluid, and it's just giving a steroid and a Novocaine-like material to take away the inflammation and the pain. And you use it in the back. You can use it in the joints. You can use it in the neck. And most of the time, people don't get sick from it. But it does give you a steroid. There might be some side effects, and there could be a low-grade infection.
Yeah, there could be. Or, you know, if you get recurrent, you know, injections, then there's some side effects that might go along with that, too. Sure, yeah.
The effect of the steroid is usually gone within about a week or 10 days. We use long-acting steroid and an epidural. These can be done in the neck or the lower, probably a little bit more common in the lower back. But there can be some accumulation too if one has had more than one injection. You know, you can get some steroid, but most of that effect should be gone within certainly 2 weeks at the outside. So if something was going on longer than that, I would be looking at things other than just the effect of the shot itself.
Yeah, or maybe another problem.
Yeah,
well, I'm supposed to go to tape, but now I've heard of such a thing as a spinal fluid leak. Could this have?
People get after a lumbar puncture where you go not only into the epidural space, but into the spinal fluid itself. And then when you're done with that lumbar puncture or you've used that type of anesthetic, it leaks. And so there's a loss of volume within that space. It's in the brain, it's in this, you know, everything is floating in a tub of water back there. If you drain the tub, it's kind of bumping against the walls and everything hurts. And sometimes what you have to do is stop that leak, and you put a little bit of their own blood around that and clot it off.
CSF leak with an epidural can happen. It's uncommon, but it can happen. But the major symptoms are headache, not just sort of a feeling of the blahs. Yeah. So I wouldn't think that'd be involved here either.
Good question. Okay. Sarah, any comment?
All right, well, we'll go to the tape again. Last month, South Dakota State University hosted a speaker recognized nationally in the field of animal science. This speaker is renowned not just for understanding livestock behavior, but also for understanding human behavior, more specifically the developmental challenges of autism. There's a buzz of expectation in this crowd. Ranchers, students, and agricultural business leaders have come to hear a woman designated one of Time magazine's 100 most influential people of 2010, Temple Grandin. Grandin is a nationally recognized expert in animal welfare and animal facility design, and she holds a PhD in animal science. Grandin also has autism. She credits the strong support of family members and teachers as crucial to helping her develop.
One of the most important things, and I can't emphasize enough, is early educational intervention. I mean, I had a great speech therapist who worked with me several times a week. My mother hired a nanny when I was 3. Who constantly played turn-taking games with me and my sister. The worst thing you could do with a young autistic kid is to do nothing. You got to get 20 or 30 hours a week with these little 2- and 3-year-olds with an effective teacher.
Autism is a disorder that affects an individual's ability to communicate and interact with others. Grandin's willingness to share her story has broadened the understanding of autism spectrum disorders worldwide. She is the author of numerous books that discuss how the mind of an autistic individual functions.
I think totally in pictures. But I want to emphasize that some so-called non-autistic people also can think in pictures. Thinking in pictures is a continuum. You know, I just have an extreme form of thinking in pictures where I can test run equipment in my head. When I design equipment, I thought everybody could test run equipment in their head. I didn't even know that it was a special skill.
Grandin is recognized throughout America as a leader in two fields, autism awareness and animal science. In both of these areas, she strives to share her understanding of the value of education and effort.
It takes a lot of hard work. I've always talked about the importance of developing ability. When I was a little kid, I was very good at art. My ability in art was always encouraged and developed, and my ability in art became the basis for my design work. But I want to emphasize, learning how to design cattle handling facilities, that took time.
If you'd like to learn more about Dr. Temple Grandin, either in regards to autism or livestock behavior, you can find out more online. Dr. Grandin's autism website can be found at templegrandin.com. Again, that web address is templegrandin.com. And for professional information about livestock handling, her web address is grandin.com. Again, for livestock information, go to grandin.com.
Among U.S. residents ages 65 years and older, 10.9 million had diabetes in 2010.
Thank you for joining us tonight. It's your chance to ask anything about healthcare, and here in the studio ready to answer your questions are Dr. Thomas Braithwaite, Dr. Sarah Smith, and on-call medical editor Dr. Rick Holm. Now, do you want to follow up on autism, or do you want to dive into the stack of questions?
Any comment about autism? Sarah? She's a functioning autism person.
Yeah, I mean, I think she's pretty high functioning. That's amazing. I think, you know, I really think that families, my comment about autism is that families can feel really isolated. And, you know, so needing to find support. And like she said, you know, in the interview, she talked about making sure that there's early intervention. We need to support these kids. We need to support these families until we find a cause and a cure and, you know, all those difficult things. So
it goes with everything. The value of social support is huge. I mean, my wife was telling me she saw on TV the other day that they were talking about that breast cancer patients do better when they have a support group versus the people who don't. The support groups are huge in prognosis. I mean, actual physical deterioration of the whole 9 yards. What do you think about that?
I think it's absolutely true. Yeah, absolutely true.
I don't want to spoil anything for our viewers, but when Dr. Holm talks later, he's going to be talking about getting together in groups in his editorial piece. So stay that's good. Yeah. Okay, we'll dive back into the questions. Caller from Clark: where can a person research medical conditions such as polymyositis? Excuse me if I'm polymyositis if they do not have the internet?
Ooh.
Does your public library have a computer? You might be able to
get a friend who has the internet. Call the library.
Call the library.
And ask them to send you some information. They'll research it. MedlinePlus.gov is a good site. We've got a number of sites to look at if you go to our site, which is
oncall.sdstate.org.
So, but
you tried to stump me there.
I did, but if you don't have a site, I think the library, you know, you could find a library somewhere and mail it to you. Mm-hmm. State library, call it.
I think a librarian would help you look it up. Absolutely.
Yeah. Okay. A question from Carthage. A lady has Hogan's disease in the eyes. What is this, and what are the symptoms?
Hogan's disease. I know, Sarah, you know the answer to this.
Hogan's Heroes I know about, but I think since you said we wouldn't be stumped, Rick, we'll send that question to you.
It has to do with when you've been watching too much late-night TV, your eyes blur over, and what you do is you go to your local primary care eye doctor.
Okay, so and that may have been, you know, lost in translation in getting the phone call, but
don't know what Hogan's disease is. I don't.
Okay, talk to your doctor.
We got stumped.
Let's see. Okay, a caller from Sioux Falls, a lady. Her husband got water in his ear. He's now dizzy when he wakes up in the morning, and it's sometimes ringing in his ears. Is there a connection? What might be the cause?
Yeah.
I don't have an age on that.
I mean, the eardrum should protect the inner ear from getting fluid in it, but if he has an you know, a defect in the eardrum or something that might, you know, cause problems, or if there's retained water in the ear. I mean, go get it looked at first of all. Make sure there's not a big chunk of wax or something going on in the ear canal, something that might be easily fixed. I think do that first, and if the dizziness persists, then there's other tests and other things that your physician can do for you.
Most common cause of dizziness is a viral infection of the inner ear. It happens. There's nothing you can do really but keep moving, do range of motion exercises. There's some positional things that sometimes happens when a little calcification in the semicircular canals occur. You need to go to a professional for that. But I don't think it's the ear water. I think that's
I doubt there'd be a connection. Well, also the ringing, what we call tinnitus, is often due to chronic ear damage, sensory neurohearing loss. So I wonder if there wasn't some chronic issue with hearing and the nerve to the ear too. So there may be more than one thing going on, but I think we'd all be skeptical that the water itself would be the triggering cause.
I see a lot of dizziness. I see a lot of ringing. And a lot of that, the dizziness is generally virus, and the ringing is generally noise exposure in their lifetime, or an inherited thing as you get older.
All right, a question from Worthing. Female, she takes Miropex, 2 pills a day, 0.5 milligram. Would it be okay to take more pills since 2 doesn't always work? What do you take Miropex for?
Parkinson's, it's a very low dose. There's a lot higher dose, but I'd advise your doctor to guide you on that. Sarah?
Or restless leg, we just talked about.
Restless leg. Yeah. But that's the lowest dose of Miropex. The problem with
Miropex... Talk to the
Miropex...
doctor before you amp it up.
The problem with those 2 drugs, Miropex, which is, I can't remember, and Ropinirole, which is, can't remember the brand name, is that people have hallucinations with them on higher doses. So, I mean, you know, it really helps some Parkinson's, but the main drug for Parkinson's is Sinemet, or it's L-dopa, carbidopa combination.
Okay. All right. Caller from Rapid City. I have severe food allergy. Is there some way of finding out what food allergy, soy or wheat, I'm allergic to? I have had my thyroid checked. So...
Sarah?
I mean, I think they can see an allergist, you know, and they can do specific testing, blood testing or skin testing, scratch testing. If there's some things that you might be specific things you might be worried about, they can have specific tests. There's also panels that they can run if you're looking for a diagnosis.
Yeah, dietary allergies are difficult. I think, you know, probably the most common, it's not an allergy, but lactose intolerance is probably the most common, or maybe gluten sensitivity, which is the cause of celiac disease, would be 2 of the more common. But sometimes tracing down dietary allergies, the skin testing may or may not be as effective, but I think Sarah's comment about seeking the opinion of an allergist would be sound. Yeah.
You know, I think 20 years ago when they said food allergies, we all went, whoa, whoa, whoa. And now the allergists and most people are saying, there's a real deal. It's really rare, but it's real. And, you know, kids, the different than the milk intolerance, these kids can get milk allergies. It's a different thing than milk intolerance as an adult. And so it's a real deal. Got to go to an expert about it, but
And, you know, don't blame your symptoms on, you know, if it's not the food allergy, look for other causes of whatever your symptoms are.
Yeah.
Bowel symptoms can be caused by lots of different things, so that would...
Celiac disease is a great topic. We could spend the rest of the show talking about that one.
Yeah. Okay.
And it's a food allergy, really. I think it's not a... It's a T cell, not a... It's not allergic mast cell type of thing, but it's an allergy.
Okay. I'll just stream ahead. There, like you say, we could keep talking about that. But a question, female caller, age 82, previously had a stroke. A few nights ago, her heart rate went up to 129 beats per minute. She took aspirin, it went down. Is there anything else that could have been done?
Tom.
So, 82-year-old.
Well, heart rate at rest of 129 is abnormal. Whether that's connected or not with the stroke is an interesting question, because we know that certain arrhythmias, particularly atrial fibrillation, which is where the upper chambers of the heart, rather than beating regularly, are shaking or fibrillating. We know blood can pool or clot in the atria and can be predisposed to stroke. be interesting to know whether she had symptoms with it other than just the sense that her heartbeat was going rapidly. But that is an abnormal heart rate, and I wouldn't say that taking aspirin was a bad idea, but there's something more at play here. And I think that would be worth pursuing further with her, talking to her physician about. There's ways we can monitor the heart rhythm at home in an outpatient setting to look for significant arrhythmias, and I think given the history of the stroke, that would even prompt me to be more curious about what that rhythm, that rapid heart rhythm, what we call tachycardia, was.
Yeah. Could be there's blood clot to the lung. Could be that there was a heart attack and it brought the heart rate. I mean, there's so many things. If you think about it, though, in that age bracket, the most common thing, I think, are these Brady-Tachy syndromes. They have these runs of fast rate, and then they'll have these runs of slow rate. And it seems like their clock isn't working real well. And if they haven't passed out and they haven't had major problems, maybe we're okay. But like you say, I think a workup would be good.
Mm-hmm. Okay. Rapidly shifting gears, and this one is aimed at you specifically. Dr. Holm, female caller, age 57. You have talked about not blowing your nose when you're stuffed up. So what are they supposed to do instead? So why do you recommend not honking away?
If you blow your nose, you close both nostrils. Actually, you close one nostril at a time. You double the pressure, and in the New England Journal of Medicine, 100 pounds of pressure. Reach is listening right now, and he is my ears, nose, and throat guy who's been contending me that I'm wrong. We couldn't find the article. 100 pounds of pressure can occur. And you know, people come in with sinusitis. What they have is pressure-filled sinuses. They've rammed that stuff in to their sinus. I think it's wrong to go honk, honk, honk. And some people, if you just sit in a restaurant, you can hear people blowing their nose hard all day. So I would say gently blowing, do the saline washing. Remember, the most important thing is to drain the sinuses rather than ram it in there. And so swallowing, anything that you suck on will make saliva. You swallow, it makes a negative pressure, and it drains the sinuses. So suck on lozenges, wipe your nose gently, and don't blow your nose hard. Do you agree, both of you?
I think that's good advice.
Okay. And Reach is going to come after you tomorrow.
Okay, I'm ready.
But you're in agreement on that. That's great. Question from Sioux Falls, female caller. Had a vitamin D test, was told to take 50,000 milligrams. Is this a lot? If so, why so much? It sounds like a lot.
Yeah, we go once or twice a week, depending on how low it was, for two months, and then go back to the 4,000 or 2,000 a day. What do you?
Yeah, in severe deficiency states, units, not milligrams, but to use 50,000 units once, twice, even 3 times a week wouldn't be dangerous if you're severely deficient. But then, as Dr. Holm mentioned, I think after usually 8 to 12 weeks, somewhere in that time frame, it'd probably be good to have the level rechecked and then back off to a more typical maintenance dosing.
Yeah. Okay.
Somewhere between 1,000 and 4,000. We don't really know the right dose, but a maintenance.
You're safe
dosing.
under 4.
Yeah. Okay.
I'm taking 2. How much are you taking?
I'm vitamin D deficient, so I'm taking 2,000 a day.
Oh, and I was 2, and I am on 2. And are you taking your D?
I'm trying to get mine through the natural sunlight that I get when I'm out at the lake. How's that?
Oh, good answer.
All right, which is one good way to get vitamin D.
Yeah, probably the best way.
A question from Sioux Falls, a female caller. Can you tell me about Cushing's disease, the causes, treatment, and is it normal for your joints to go out of your socket?
Tom,
so who wants
joints out of your sockets. Cushing's disease versus Cushing's syndrome. Do you remember? You remember, Sarah?
Cushing's disease is the disease that's prompted by excessive production. Well, Cushing's is the excessive production of adrenal gland hormones.
Right.
Okay.
And it can be either, I try not to think of disease or syndrome. I think that's confusing. But primary Cushing's is where the adrenal gland itself is spontaneously, without control, without the usual feedback mechanisms, producing too much hormones. Secondary is where there's the director gland from the pituitary is sending out too much stimulus to the adrenal gland. And the effect is the same. But the symptoms of Cushing's usually aren't joint-related problems, although one people may think of as the hump in the back, obesity, weight gain are symptoms of common symptoms of Cushing's. Uncommon disease, by the way. It's not. I've seen very, very, very few cases.
I've seen a few. I had a patient who presented with high blood pressure, emotional roller coaster, truncal obesity, buffalo hump, stria. I mean, she was classic. And it took a while to make the diagnosis. We got it. And she lost, 50 to 100 pounds when her adrenal tumor, which was benign, was removed.
Wow.
And unbelievable. I mean, all these years I've been waiting for a couple, and when she came in, I said, this is this. And it took a while to make that diagnosis. She had to jump through a bunch of hoops, but with the help of good endocrinologist, we got there. So, it's a real deal. Got to think about the diagnosis.
All right. A question from Aberdeen, gentleman age 68, has been diagnosed with Parkinson's. I take Cinemet as a medication. I'm curious about the progression of the disease, not tremors. What happens next? So you're
variable. Entirely variable. I've seen people who just jog for 10 years before they get to the point where they're having trouble jogging. Some people deteriorate very fast, and it's a progressive, severe, awful disease. Some people, it just depends upon what the cause is, and I don't think we always know. We don't know really what the cause is.
A couple variants of Parkinson's disease. Yeah. Parkinson's, I think we mentioned earlier, is a movement disorder, and some people tend to be more bothered by the tremor aspect. So some it's more of a tremor predominant disease, whereas some it's more of a slowing. The medical term we use is bradykinesia, which literally means slowed movement. And in my experience, those are the people who have the toughest time. It is a progressive disease. We know the part of the brain that's affected, but what triggers that, we don't know. And we know medications such as Cinemet that he's on, which Dr. Holman earlier said, Rick had said that's the kind of the foundational piece of treatment of Parkinson's. But we can't arrest the disease. It can be controlled, it can be treated, but it can't be stopped. But at least in my experience, if it's more tremor predominant, those folks over time tend to do somewhat better. And
that's the thing the medicine doesn't work very well for the tremor. Do you see many in Sioux Falls with the brain surgery, transplant, implant, trigger stuff going on that's working?
Don't quote me. I don't believe that's being done in Sioux Falls currently. I think brain stimulators are being done. I know I've seen patients that have been referred up to Twin Cities or to Mayo in our neck of the woods for that. But I'm not aware of brain stimulators being put in Sioux Falls. But again, I'm not. I can't.
You haven't seen them coming into the hospital for the moment?
I have not personally seen them.
Sarah?
I've seen a person with it, not as a patient, but as a friend, colleague, older colleague, and it was amazing. He's a family practitioner, and it absolutely changed. For him, it made him just much more functional as far as the movements go, and being able to do his day-to-day activities and continue to practice. And it's really pretty, turn it on, turn it off. It's amazing, so.
There's a lot of research going on. A tough disease, it's variable.
Now, other than, working with your doctor and having your medical team on track with what's going on, are there lifestyle do or don'ts when you have Parkinson's?
Absolutely. Keep moving. It's the most important thing you can do. It's true about everything. I've said that before. But it's the most important thing with Parkinson's disease. And I sense that if you can keep your movement going and your muscles working and your coordination working, and it takes a lot of effort, but then I think that's a huge part of it.
I think with one other caveat, and that'd be protection against falls, because this is a disease that affects balance. And so activity, I agree 100%, Rick, but I think just being careful about fall prevention, because this is
with our elderly population too. We encourage
but this is just a real high risk.
It's a real high risk
population for falls.
I'm going to have to ask for a quick response on this one. Question from Sioux Falls: is there anything the caller can do, a lady, to get her sense of taste back? Lost it for about 2 years. Heard it can be from medicine, age, or virus, and she just wants to be able to get her sense of taste back. We got 30 seconds before we get to our wrap up. What kind of physician should she see to talk about this and get some answers?
The priest. I've seen it. Steroid nasal sprays, is an important thing, because you can turn off the inflammatory process, make sure you're getting enough vitamin D, make sure that there's no infection.
tough problem. And I think the other thing, although it's rare, but you would want to make sure a central cause. If they can say this started at such and such a time. If someone ever came into me and said, you know, about 2 months ago, I suddenly inexplicably lost my sense of taste, and we couldn't see dietary change or medications, I think you'd want to at least take a picture of their brain and make sure that there wasn't something centrally that could be causing that. Because the very base of our brain, the olfactory lobe, is where taste is all perceived. So although it's rare, I think it would be worth considering.
B12, thyroid testing, and look for underlying cancer. Yeah. Any final words? We've got 10 seconds.
Great show.
Great show.
Fun to be here.
Fun to be here.
Invite me back when it's warmer.
Oh, I will. Thank you so much for being here.
Okay. Well, thank you so much for being here, doctors, and stay tuned. We will be right back with the Homespun Perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the OnCall website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Something changed in my life 2 months ago. A nurse at our hospital asked if I would like to join her Doing It Daily challenge for $20. She said I should turn my 3 days a week exercise program into a daily habit. All I'd have to do is walk, run, or bike 1 mile on the days I'm not usually working out. I thought about the 4 days a week that I don't exercise, how busy I am, and wondered how would I find the time to do it. 1 mile is only 12 blocks, she said, glaring at me with the dare. It's $20 to take the challenge, and those people who are still keeping the promise of doing it at least a mile 6 days out of the week after a year will split the pot. So my wife and I both threw $20 into the kitty with 35 others and promised to try to get that mile in every day. At first I thought of it as a nice donation to help encourage other exercisers, but I've been doing it 6 days out of 7 for 2 months now. On the 4 days a week I used to take off, I now walk the 6 blocks to my studying spot, a local cafe, in the early morning, and then home again before work. Something this good is worth sharing. So I offer the same challenge to you. Start your own group with a $20 pot or a charity gift plan, or just do it for fun. Simply walk, run, or bike at least 1 mile a day, 6 out of 7 days. If your physical condition presently can't handle a mile, then make it something shorter. One friend suggested walking the dog 6 blocks twice a day. That would work, but do it daily. I could mention here all the great things walking can do for you, including better bone strength, energy, memory, and aging with grace. But that's not the main reason to do it. My morning 1 mile walk has become a pleasurable time to observe the beginnings of the day. And it is easy, and it makes me feel remarkably good. And what's more, I just might win some money. I dare you to do it too. We'll be right back.
Before we get to our medical news tonight, we had so many questions tonight. Our doctors are going to try and jot quick responses to them, and we'll post that on our website. So you can go to the OnCall website, oncall.sdstate.org, and look for the answers there. There might be an answer for you. Now, in our medical news tonight, the lowly lab rat has again made a contribution to science, this time in regards to diet and vitamin D. In previous shows and in this show, you've heard the doctors on OnCall talk about the value of vitamin D. New studies show that it may be beneficial for a lot more than building healthy bones. Some research indicates that vitamin D deficiencies contribute to heart disease, cancer, and other health problems. We get some vitamin D from the food in our diets, and we get some from exposure to the sun, but a lot of us still seem to have lower than normal levels of this important compound in our bodies. And this is where the lab rats come in. Scientists are experimenting with new ways to add vitamin D to our diets and have come up with a bread made from high vitamin D yeast. In the rats, the vitamin D from this bread seemed to be just as beneficial as vitamin D from sunshine. And moving on, it's time to wrap things up now. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guests for this evening, Dr. Thomas Braithwaite, Dr. Sarah Smith, and our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, some great SDSU students, and thanks to you for watching and calling in. Have a good evening.
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by On-Call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Biocommunications at South Dakota State University.